George Adams, interventional cardiologist, UNC Rex Healthcare. Today, we're going to be discussing the 12-month results from the TOBA 2 below the knee trial. I'd like to personally thank Craig Walker and NCVH for inviting me to speak on this digital education series. When we talk about chronic limb-threatening ischemia, it afflicts about 2 to 3.5 million people in the United States. Treatment of below-the-knee arteries for CLTI patients remains based on angioplasty. However, the complication that occurs with angioplasty by its mechanism of action is dissections, and these dissections frequently predict restenosis. I'd like to introduce a solution to these dissections. This is the TAC endovascular system. It was FDA approved in April of 2020. As you can see here to the right, this TAC implant system has 4 preloaded nitinol implants. Each one of these are 6 millimeters in length and can treat a range of vessels from 1.5 to 4.5 millimeters reference vessel diameter. This is an over-the-wire delivery system, 4 French, going over an 0.14-inch wire, has 150 centimeter working length, and has accurate deployment. The data supporting the TAC endovascular system is pretty vast. As you can see, there have been 3 trials to date above the knee with very good efficacy and safety. Today, we're going to be focusing on the below the knee trial. There are 2 trials to date. Most recently, the 6-month data was presented for the TOBA 2 below the knee trial. We'll be discussing the 12-month data, but as you can see from the 6 months, again, very good efficacy and very good safety. Remembering the design and follow-up of the TOBA 2 below the knee trial, remember, these enrolled patients with critical limb ischemia and angiographic evidence of dissection post-PTA requiring repair in the mid-distal popliteal, tibial, and peroneal arteries. It enrolled 233 patients at 41 U.S. and international sites. The primary endpoints: safety, major adverse limb events, and perioperative death at 30 days, and efficacy, freedom from major adverse limb events at 6 months, and perioperative death at 30 days. The secondary endpoints included TAC segment patency at 6 months, looking at duplex ultrasound, and target limb salvage at 6 months. There were several key observational endpoints, as you can see here, as quality of life metrics and wound status. I'd like to thank the TOBA 2 below the knee investigators, all seen here. If we look at the demographics of the population, the majority were older, about 75 years of age on average, male. If you look at the Rutherford classifications, the majority were critical limb ischemic patients at Rutherford 4 and 5. They had high comorbidities for this critical limb ischemic population. As you can see, the majority of them smoked, the majority of them had diabetes, almost all of them had high blood pressure, and a majority had coronary artery disease, and a significant part of the population had critical limb ischemia, which comprised about a quarter of the population. Going back to that comment I made regarding the device being able to treat a 1.5 to 4.5 millimeter reference vessel diameter, as you can see, depending on where you were in the tibials, decided how large that tibial was. So if it was in the proximal segment, it was 3.5 millimeters on average, and then distal 2.6 millimeters on average. You can use one of these TACs to treat each one of these differences in diameter. As you can see here, the lesion length on average for post-balloon angioplasty was 154 millimeters, and about half the patients had chronic total occlusions. Regarding calcium, the majority were none to mild, and as you can see, almost all of the lesions treated were tibial vessels. Now, this is an interesting slide. If you look to the left to begin with, the dissections on average per patient were about 1.4, with a length of about 24 millimeters. Remember that the dissections were decided to be treated by the operator. And operators thought that if you look at the grade of the dissections, the majority of them were from A to C. And remember, typically a C dissection is a flow limiting dissection, with A and B not being as severe. Device success was approximately 97%, with 100% of dissection resolution per the core lab. In terms of bailout stent, it was low, and especially to the TAC segment, it was low. The average number of TACs per patient was 4. And remember, there are 4 that come in each sleeve for each individual system. Now, if you look to the right, now this is an interesting slide. As you can see, this shows exactly where the TACs were placed of the patients that were enrolled. 35% of these TAC implants were deployed in the mid and distal tibials. Why is that important? Because this is typically a taboo area. We typically don't put scaffolds in this region, but in this trial, 35% were placed in this region. If you look at the 12-month X-ray of TAC implants, there was no fracture, migration, or embolization. Now let's look at some of the results. First, in the below the knee trial, as you can see, it met both primary and secondary endpoints. The primary safety was met at 1.3%. The primary efficacy, the freedom from 6-month male and 30-day perioperative death, was met at 95.7%. The secondary efficacy, 6-month TAC segment patency, was met at about 82%. And then the unpowered secondary, the 6-month target limb salvage, again, was high at 98.6%. Now, when we talk about TAC segment patency and target lesion patency, okay? So first, let's define them. If you look as I talk to the right, and we'll make this real by looking at an actual angiogram. So TAC segment patency, this was duplex ultrasound, either flow or no flow, in the TAC segment, and that was defined as the TAC implant plus 5 millimeters artery proximal and distal. If there were 2 TACs within 1 centimeter of each other, they were considered the same segment. So if you look to the right, there are 2 TACs here that are placed. These are obviously the TAC segments. In between the TAC segments, there's an area of no scaffold, and it is less than 1 centimeter. So the whole segment is considered the TAC segment. When we look at the target lesion patency, this is duplex ultrasound, no flow or no flow, in the PTA treated length. And as you can see here to the right of the slide on the angiogram, this shows you that the balloon treated length was longer than the TAC segment, which we would typically assume. Now, let's go to the results. So on the x-axis is time in days. On the y-axis is percent of the population. And as you can see, out to 12 months, the target lesion and first of all, the target segment or the TAC segment patency at 12 months was 81.3%. Target lesion patency, 78.6%. When you add in clinically driven TLR to the definition of target lesion patency, it was still high at 72% out to 12 months. Now let's talk about target limb salvage. As you can see, for the whole population, it was high at about 97%. When you just look at the critical limb ischemic population, Rutherford class 4 and 5, it was still very high at 96.1% at 12 months. When we look at the freedom from clinically driven TLR, at 12 months, it was 83.1%. When we look at amputation-free survival, again, high for the total population at about 89.3%, and it doesn't change much when we just focus in on the critical limb ischemic patients of Rutherford 4 and 5 at 89%. Now, looking at toe brachial indices, there was an improvement at 6 months compared to baseline that was significant, and it's maintained out to the 12 months. If we look at the percentage of wounds healed and wounds healing, it was about 85% of the total population that fell into this class. Again, very impressive. Now, looking at sustained improvement in Rutherford class. So on the y-axis is the percent. On the x-axis is Rutherford classification. On the z-axis, as you can see here in blue, is baseline. In yellow is the 6-month data. And in the green is the 12-month data. As you can appreciate, about 60.4% of the patients improved greater than or equal to 3 Rutherford classifications. And about 80% of this population, if you look at the Rutherford classification out to 12 months, improved or were in the 2 classifications, either Rutherford class 0, 1 or Rutherford class 2. When we look at quality of life metrics, again, all of them improved. Mobility, pain, daily activity, and general health out to 12 months. So in conclusion, TAC is a new therapy for dissection repair. It's the first below-the-knee vascular implant to achieve FDA approval. It's a unique trial. It's the first below-the-knee IDE study to enroll 100% of dissected vessels. The TAC implant was successful. It repaired 100% of the post-PTA dissections. When looking at the 12-month results, there was no fracture, migration, or embolization of the implant. There was 81.3% Kaplan-Meier TAC segment patency, 83.1% Kaplan-Meier freedom from CDTLR, and there was sustained improvement in Rutherford classification, toe brachial indices, and quality of life metrics. CLTI, the Rutherford 4 and 5 patient outcomes were high, with 96.1% of the Kaplan-Meier target limb salvage and 89% amputation-free survival. It is my pleasure to present this, and thank you very much for joining me today.